MST can be a very challenging program and therapy, but it's also super rewarding. So a little bit about MST. We are an evidence-based practice, so there's a lot of research to back us up in our efficacy. Overall, MST as a whole, and this is across the U.S. and abroad, they have outcomes with 90% of youth living at home versus being at placement or some sort of juvenile incarceration. 86% of them at home working or going to school, so that's great. And then our big thing is 87% of no new arrests. So really having a great impact on the recidivism of youth. Personally, for our programs here, we are slightly a little bit lower than that. All of ours percentages are in the 80s, though. So we have 80% living at home, 80% working in school, and 80% with no arrests. So that's pretty awesome. There also are longevity results for this. So after 14 years, it's been correlated with 54% of fewer rearrests. And then 22 years, 75% fewer violent felony arrests. Wow. So huge impacts. So MST as a whole is designed to work with caregivers to help impact youth behavior. Our whole theory is that the caregivers have the most influence over a kid. Now, there's a lot of competing contingencies there. So we have those systemic factors coming in: school, home, peers, just culture in general. So, but our thing is those caregivers can influence all of that. So our whole goal is we're going to do literally whatever it takes to help that caregiver make some changes to those systems to help impact the youth's behavior. So our whole goal is to keep them home, out of any sort of out-of-home placement. We would like them not to have any new arrests. However, sometimes we have kids that come in with super serious felony offenses, and maybe they just get a misdemeanor offense or even just like a district magistrate citation sort of thing. So yes, technically still reoffended, but on the severity level, much better. Yeah. So MST has 3 core elements. We have our 9 treatment principles that kind of goes over all of our treatment. We have an analytic process called the do loop. So basically that is, we just get in, we identify what behaviors are going on. We ask each participant, kid, caregiver, school, probation, really anyone involved, what's your desired outcome here? Sometimes that ranges from, I just want to get off probation so I get these people off my back. That's fair. Sometimes is, I want my kid to come home. I want my kid to be in their bed at night. So it just kind of depends. So we identify their desired outcomes. We work on the strengths and needs across all those systems. So we talked about how we're systemic. So what are the strengths and needs of the peers, the school, the neighborhood? And we really use those strengths to help develop interventions. We then do something called a fit circle, which is we look at every behavior and we put it in a nice little circle. It's great. And we look at all the different factors that contribute to it. And
so these are non-preferred behaviors or non-desirable behaviors?
So we would say, let's put truancy in the middle, right? Okay. So we have truancy in the middle, and then we're going to sit and say, what's contributing to this? Tell me what's going on here. So we'll sit and talk and say, okay, well, what does your morning routine look like? Well, I don't get up. Okay. Mom tries to wake me up. Okay. Do you set an alarm? No. So all these things. Do you know anyone at school? Do you talk to anyone at school? Some of our kids are bullied, so we have some negative peer stuff. Sometimes our kids have missed so much school that they're in technically 11th grade, but their academic level is not at that point. So they might be at a 4th grade level, and so it's intimidating to go into school. They almost feel like they're set up for failure. So all these are drivers that we look at. Once we figure out what the drivers are, we then sit and we prioritize. As a group, we pick out with the caregivers, with the team, what driver are we going to work on first? And sometimes for truancy, that could be an AM/PM routine. That could be, let's get connected with the school. Let's find one person at the school that we could leverage as a good support. And then we work on interventions to make that happen. We help them implement those interventions. Ideally, they work great. Realistically, we run into some barriers. So then we talk about what barriers do we encounter? How can we overcome that? And so it's kind of a nice little system. That's what we call the do loop, that bottom part where we implement interventions. We assess, was it good? Was it not good? If it was good, great. How can we sustain that? If it was not good, let's go back and say, what was not right with our intervention? Do we need to drill down to further barriers? Maybe we targeted something completely that wasn't the best to target. So we keep going around and around, which is great. But we do that every week. So there's supervision within that. Therapist and team, family do it together, and then we come to supervision. I look over it. We have a consultant that looks over it to make sure we're on the right path. But maybe we also look to see, hey, you didn't think about this. Let's, just in case this pops up, have a plan for this. So we continue to work through treatment like that. And then we also have a quality assurance system within an MST. This is one of my favorite things personally, because this is where you can see on paper how well we are doing, but not just how well we're doing as a program, but as an individual therapist. So each month, each family rates each therapist on different measures. Are we adherent to our model? And so it'll ask, are you sure about the direction of treatment? Have you worked on school behaviors? We've worked on family relations. So there's a lot of different factors. And then we have this lovely system that we put it all in, and it generates the data. So it really tells us what we're doing good at as a therapist, but also like, oh my goodness, I didn't realize I'm really struggling on being positive and strength focused with this family, because sometimes that happens. So it helps us figure out where we need to target, which I love. But also within that, the therapists do the same thing for me and our consultant. So they measure me every other month and our consultant every other month. Are we adherent to the model? Which is nice because things happen, and sometimes I'll be real good at things, and then I might not be so good at updating their clinician development plans, although I've done better with that because that was a neat area. So it helps prioritize, and we're always continuously working and learning. So it's you're never feeling stagnant. There's always movement forward. And then as a program, we do that overall every 6 months. So every 6 months, we look at the data and say, where are we doing really well and where we're doing okay, but I'd like to see improvement. So we come up with really specific interventions for each program that I help work on and the therapists really help work on. So not only do we have a real great system of helping our families, but we use that same system to help build and maintain skills for therapists, for the supervisor, and for the program as a whole. Which I love. As part of MST, we use a few different treatment modalities. They're all evidence-based. So we use behavior modification, cognitive behavioral therapy, pragmatic family therapy, and contingency management. So I can't say at one time, this is a case that I'm definitely going to say we're going to do some family therapy on. Because it may be that is not the case at all. It just kind of depends when we go back to that fit, whatever those drivers are. If we identified a family conflict driver, that's what we're going to go with. And so we're going to use family therapy skills for that. If we land on a ineffective expectations, poor delivery, inconsistent, I might land on behavior modification interventions. So we're always kind of working. Sometimes we'll have multiple going at the same time, especially when we have expectations, rewards, consequence interventions. In order for those to be effective, we have to have that relationship with the caregiver and the youth. So we might be like, you know what, we got to work on that first and go do some family therapy stuff. So it's always kind of going. Overall in treatment, we really help caregivers improve supervision monitoring, structure, expectations, discipline, rewards, family relations, decreasing negative peer contact, and improving school attendance and performance. Typically, our treatment is 3 to 5 months, so where our whole goal is to get in there, do the hard work, and get out quickly. And we do that with typically 2 to 3 sessions a week. That can be a lot for a family because we're in crisis. That's a lot. We're in your face. But it doesn't have to be I'm sitting here doing like lay down on the couch, tell me about your life for 2 hours at a session. This is, we're action oriented. We're getting in there. Okay, we had an AM routine. What's going well this week? What's not going well? All right, I'll come tomorrow. We'll assess together what's going on. So it doesn't have to be sit and talk about things. It's very action oriented. We're doing it all together. So, referrals, our youth, what we take is 12 to 17-year-olds. They have to have a mental health diagnosis. They typically, we get a lot of conduct kiddos, oppositional defiance, ADHD, PTSD, really pretty much anything. We don't discriminate. We'll take autism level 1, level 2 and 3 we don't. There are facets of MST that are specialized that do work with lower functioning autism or even child abuse neglect. So there are super subsets of it. We just do our typical MST for us here. Typically, our kiddos are engaging in verbal and physical aggression, property destruction, curfew violations, theft, runaway, substance use. So think of your typically, quote, delinquent kids. You know, the kids that you would think, oh, they're going to be in juvenile detention. Those are our kids, but in the community. They have to have a caregiver who's willing to participate in MST because that is our bread and butter, working through that caregiver. So it doesn't have to be a biological caregiver. It doesn't even have to be if they live with mom and dad, but grandma's there and grandma's like the primary support person, we'll work with that grandma. It can be the neighbor next door. So as long as we have someone there that can help change and impact things, we're good to go. Typically, our referrals come through county resources, so children and youth or probation, because we do have contracts with them. But we can also get referrals through psychological evaluations and written orders. Pretty much from anyone that could sign off on any of those, we can get referrals from. So we have a wide range of kids that we can see. And every referral that we get, I sit down, I go over it, I call the family, explain what it is, and really make sure they know what they're signing up for. Because we are intensive. We're a lot. And I want to make sure they're okay with that. We also have to make sure we can't take any kiddos that are actively homicidal or suicidal. Nor can we take any that their primary referral behavior is a sexual offense. We have had kids where that may have been one of their behaviors, say like 3 or 4 years ago, but right now they're engaging in theft or runaway. So because that's not the primary behavior, we can help with that. But if that is the only behavior going on, we particularly are not trained to help with that. So we refer to other resources. So a good person that would work for MST, you definitely have to be flexible, right? You have to be energetic, independent, good with communication. So not just with me, but with families, with probation. You're interacting with so many people. A desire to help others. Honestly, that's the big thing. A desire to want to help make change. To be strength focused, even in the muck of everything, when a kiddo is running the streets and maybe they have their own little like side hustle going on that like probably not the best, but there's so much resiliency in that. And we just need to use those strengths in a different sort of light. So like being able to see that, I think is super paramount to this position. That way you're not as bogged down when things get crazy, right? So being able to see those strengths. A good MST therapist is good with flexibility. They're motivated. They're okay working in the home and community, working a non-traditional schedule. So our motto is whatever it takes. We will go out to families at 7 in the morning if we have to help with an AM routine. We will go out at 10 o'clock at night if they call and say, my kid's trying to leave and I don't want them to leave. Help me out. We'll be there. We are on call 24/7. We do have a nice little rotating on call. So no one's on call 24/7. It's like 24/5. But we try to help balance that out. But we're always there for our families. So it's not a 9 to 5. It is maybe I have a session at 12. Maybe I don't have another session till 5. I've had some therapists that used to work Tuesday, Wednesday, Thursday with clients, and Monday and some Fridays for paperwork. And if that's what works for that therapist and those families, that's great. I have therapists that are very good at doing paperwork, because there is a lot of paperwork where mental health can't get away with that.
Funded by,
yes,
like an
insurance.
MCO.
Yes,
Yeah.
Insurance company. Yes. Even the counties, they like their data. They like their papers. So we got to document, right?
Yeah.
I have some therapists that are really good at doing documentation right after a session. I have some that do it at 2, 3 in the morning, which is totally fine. If that's what works for you, great. So it can be super flexible, but also it's at the needs of the family. So again, it could be mom doesn't get home till 6, so we got to go over for 6 o'clock session. We do have a small caseload of 4 to 6 typically. The reason for that is we are whatever it takes. I want to see at least 3 hours with each family a week, but there's going to be times where our families are in crisis. They need more support. So you may spend 6, 7, 8, 9 hours with the family that week. If you had a caseload of 10, that's impossible as one person. So we have a smaller caseload, helps with the balance. Each therapist is responsible to work with that family and engage everyone in that family's ecology. So you're checking in with school, probation, children and youth. If grandma, they say, hey, listen, grandma could be a support, we're going to call up grandma with a release, but we're going to call up grandma. So we're really getting everyone involved. We are also making sure that we're following the model. So it's very much, yes, we're action-oriented, but we're doing all the steps that we identified in supervision. And myself and our expert are going to hold the therapist accountable to that. The therapist does get clinical supervision weekly, so they get an hour and a half with the supervisor, me, once a week, and then we get an hour with our consultant on top of that. Supervision is very structured. I do prep for that. I figure out what are the strengths and needs. Here's where you're doing real well. Here's where I'm like, let's try to tweak this, or here's some things we're anticipating as a barrier. And so we give a lot of support. If therapists need support outside of that, I'm on call 24/7. They can reach out to me. I've set up individual sessions, supervisions outside of that. So there can be a lot of support as needed. I also will go out to therapists to sessions as well.
It's like a live supervision.
Yeah, I love it. But I struggle, I'm not going to lie, I struggle not to take over. I know, Kate, I've done that to you. Where I go out and I'm just like, oh, it's so in me, I just want to jump in and do it.
Let you do your thing.
Yeah, I know, but it's not helpful. But I just love it. I love getting out with the family and doing the work. So I also will do that. Therapists also, like I said before, they have clinician development plans. So we formally update those once a quarter. But I actually work on those. I don't think they know this, but I work on them with them every week through supervision. So what feedback I give in supervision is based and tailored upon their goals and their clinician development plan. So they may not realize that, but I always have something going with their goal. It's done jointly, so it's kind of like a mini treatment plan. I have one. It's great. Typically what I'll do is I'll go over the day and say, hey, listen, this is where I'm feeling like I want to go on this for you. And then I have them pick a goal. So sometimes they want to learn more about, maybe I'm not so good in family therapy, so we're going to add a family therapy goal. Sometimes it's self-care. Sometimes it's, how do I manage a session when caregivers are just loud and they just they take over, and I don't know what to do. So we tailor it to everyone. There's also a lot of training for MST therapists. Initial training at a company level, we do myself, and then I have shadowing, and there's a lot of support. But MST Services, who is like the head honcho of MST, they have a hybrid orientation model. So now it is e-modules, and then 2 days of in-person where they do kind of role plays and they really test out what was discussed and worked on in those e-modules. And then we get quarterly boosters on top of that, which they're my favorite. Also, we do it at my house, so my dogs are there, so it's kind of great. But we pick a topic, and we really get to learn about it. And then each therapist walks away from those boosters with interventions to use immediately with their families. So that's what I love. It's super helpful. I will do trainings. Typically, I did it once a month earlier, but if we're learning about a skill and there's a theme across therapists of maybe we're struggling with school interventions, I'm going to do an hour training 1 month on here's some interventions for school that I really think we could all use a refresh. So always kind of learning, growing. It's great, to be honest. So the great things about MST, we do the hard work, we get in there, we have pretty decent outcomes for the difficult youth that we work with. But I like that we take the model that we work with our youth for ourselves, for supervisors, and for the program. So there's a lot of accountability. We're never stagnant. We're always moving forward.
Getting the darkness away or out or in a closet, wherever we want to put it, that we sometimes neglect to say, like, this is working and that is and brighten up the space. So I love that that's like the crux of the model.
Yeah, and I was also going to say, too, the most rewarding thing for me is just working with families and everybody involved. So like what Elise mentioned, probation, CYS, just like anybody involved at all, and helping them through their like absolute rock bottom with the kid and just seeing so much growth with like towards the end of treatment. So.
And I like that services are individualized for each family. We meet them where they're at, and try to help them move forward.
I imagine it's not always a voluntary service, right? Is it?
Correct.
It's not always.
Sometimes it is court ordered.
Okay.
I mean, ideally, it's mental health, so it's always voluntary,
Yes.
right? They do court order.
You have an option. You can go to jail if you
Right. I mean, you have other sanctions if you don't follow through. So there's definitely some that are reluctantly being pulled into treatment.
How do y'all go about engaging those reluctant families or reluctant caregivers or reluctant adolescents and kiddos?
I think really meeting them where they're at and, acknowledging that, especially going into people's homes, it can be a little stressful, uncomfortable, and just, being really appreciative, empathetic towards the situation coming in. We really want to help in any ways that we can, and kind of emphasizing that we are really there for them, because a lot of the time these individuals have also had other services and stuff in place that maybe weren't successful, and they're tired. They don't want another person coming in their home and working with them. So kind of showing that MST is different. I know I had a hard case with a kid who had some criminal charges, and he openly said, "I'm not going to talk about my feelings with you." And we didn't go the full treatment, unfortunately. But, we would play checkers together. And through that, we kind of, talk through his feelings, those kind of things. So really meeting them where they're at, and showing that we're on their side. We want you to succeed. We don't want you to, recidivize and go back to those charges. How can we
It sounds like you have an opportunity to get really creative in
Yes,
service
yeah.
of that individualized treatment plan. I hear a lot of different modalities really like tout that as a value. And then if I look at one provider's treatment plans, they all look the exact same. And there isn't that individuation. And it sounds like in MST, you can really get creative and look at it by behavior by behavior by behavior
Yeah.
and address it in a way that's more effective.
Right, and customization is basically what I was trying to say.
Yeah, no, that makes sense.
Yeah.
Any other bits and pieces that we failed to mention, or that y'all think would be useful for somebody who's considering MST in some capacity?
I think emphasizing the wide variety of clinical experience you get in the position. So whenever I was getting my master's degree, I was at RBT. So I'm definitely familiar with the behavior mod. And then kind of transitioning into this, being able to take what I already knew and what I had learned in my master's program and apply it and really see how, involved we can be and all the different interventions like the air tags. In outpatient, you're not sticking air tags in kids' shoes. So
No, these kids don't come to outpatient.
What?
They don't even come to the office.
No.
You don't get to see these kids
Exactly.
in outpatient because they're not coming
No,
there.
no.
You have to go to their house. You have to go to where they are.
exactly. And just, all the different things you see. No case is the same. And just all the different clinical skills that you use on a daily basis.